Hello friends, so today we present the second part of our series of videos on macular hole. So in the last part we discussed what is a macular hole and what are the different stages of macular hole, and then I also shared that what is the treatment of choice depending on which stage of the macular hole we are in. So for example, I told you that for stage 1 macular hole we can observe, and only from stage 2 onwards we have to consider doing surgery. In today's video we'll discuss how we do macular hole surgery and also answer few other frequently asked questions. Before we start, let me give the answer to the quiz that we ended our last video with. So last time I showed a patient's eyes, a case where both the eyes of the patient had a macular hole. And my question to you all was, which eye should we operate first? Now, if we review the macular holes in these two eyes, this is the right eye, this is the left eye. So the right eye and the left eye, we clearly see that there is a vitrofoveal separation which has occurred in both the eyes. So both are stage 3 macular hole. So stage wise, they are similar. So as I said, you operate on the stage which is less. So if it was a stage 2 hole in one eye and stage 3 in the other, we'll operate the stage 2 hole first. But if the stages are same, then what should be our criteria for choosing the first eye? It should be size of the hole. And if we see here, now this hole is around 360 micron and this is around 611 micron. So this is the smaller hole. And that means this is a more recent hole. Because it's a more recent hole, so it is more likely to gain vision. So it does not mean that I won't operate on the right eye hole. We'll operate that eye also. But if we operate the left eye hole first, we are likely to gain more vision. And if we delay this surgery further, we'll lose vision. Because if we operate the right eye first, we cannot usually, it's difficult to convince the patient to undergo the surgery for the other eye, say within a month. So why lose even 30 more days? Let's close this hole because this eye has greater potential for recovering vision. And then maybe after a month, we can operate on the other eye too. So with that, now let's move to today's presentation. So today we'll discuss, as I said, on how we do macular hole surgery. And in this presentation, the questions I shall answer or try to answer are: what are the steps of macular hole surgery? How long does the surgery take? And is it very painful? What precautions a patient should take after the surgery? And how long does it take to regain vision after the surgery? So the first question is, what are the steps of macular hole surgery? Step 1, obviously, we have to enter the eye. We are operating on the retina, so we have to go deep inside the eye. And for most surgeons today, the preferred way of entering the eye are what we call micro incisions, which are basically a trocar cannula system where you insert this trocar, and we make three such entries. One for the infusion, that means the fluid that will keep the eye stable, and two on the top. The dominant hand is with which we hold the vitreous cutter and the other eye, and in the other hand we hold the light pipe. Now if you see, the color of the trocar has changed here because the previous video was of an Alcon 23 gauge system. This is Alcon 27 gauge system. That means a system which is even more, where the trocar is even more thin or narrow. And this again you can see is some different type of trocar. This is metallic trocars belonging to the Oatley's OS4 system. So once we have made these three sutureless trocar entries into the eye, the next step is to remove the core or central vitreous. So with the cutter in high cutting and low suction, or you can in the center you can even keep high cutting and high suction, because nowadays most of us we do what we call proportional vitrectomy, where our hand where we keep changing the suction of the vacuum, but the cutting is more or less constant. So with that, you basically remove the central vitreous, and you try to be careful when you are going towards the periphery, because if you pull the vitreous too harshly when you are in the periphery, you may injure the retina. In macular hole surgery, you don't really have to remove a lot of peripheral vitreous. It is enough to just remove the central vitreous and a little bit of the peripheral vitreous. So this was step 2. Step 3 is a very important step, where if the vitreous has not got detached from the retina. So if you remember the stages of the macular hole, in stage 4 macular hole, the vitreous is separated both from the fovea as well as the optic nerve. That means the vitreous is completely separated from the retina. So if you are doing a stage 4 macular hole, you probably won't need to go through this step 3. But if you are operating on a stage 2 or stage 3 macular hole, there will be some amount of vitreous attachment to the retina. In stage 2, there will be vitrofoveal attachment. In stage 3, the vitreous won't be attached to the fovea or the center of the macula, but it will be attached to the disc. And you have to remove the vitreous from the retina, because as we can recall from the first video, that the macular hole forms primarily because the vitreous pulls on the retina. So unless you separate the vitreous from the retina, it's unlikely that you will be able to get a proper closure of the macular hole. So how do we induce posterior vitreous detachment? That means separating the posterior layer of the vitreous from the retina. So the drug that really helps us at this stage is what we call triamcinolone acetonide. It's a solution. So there are a lot of particles in a water-like solution, and when we inject that inside the eye, the particles get stuck to the vitreous, which is otherwise transparent, making it very easy for us to see the vitreous and pull it out of the eye. Here, for example, this is a stage 4 macular hole, where you can see the particles are not getting stuck, they are easily getting sucked into the cutter. That's because the vitreous is missing. The vitreous has already been removed in the step 2 when we remove the central vitreous, because it was not attached to the retina. So here you can see the particles are easily getting sucked out. So we have now gone through the first 3 stages: entering the eye, then removing the central vitreous, or if the vitreous is already separated from the retina, then removing the complete vitreous, and then stage 3 where we have induced posterior vitreous detachment. If you are handling a stage 2 macular hole or a very small stage 3 macular hole, so more or less you can say any macular hole which is 250 micron or less, if you operate till stage 3, it is enough. You don't have to go to the 4th stage. So what is that 4th stage? Obviously I'll share. But if you do just vitrectomy, induce PVD, and then come out of the eye, it may be enough to manage such small holes, even if they are stage 2 or stage 3. Doesn't matter, just because the hole itself is so small. Once you remove the vitreous traction and fill the eye with air, you should be able to get a good macular hole closure. However, if you have a hole which is as big as this hole, you can see 565 microns. So this is way bigger than 250 micron hole. So if a hole is more than 300 microns in size, you may have to do one more additional step, and that is what we call peeling the ILM or making a flap of the ILM. That means you have to handle the internal limiting membrane. Now, what is internal limiting membrane? So if you see, this is the retina, and the retina has 10 layers, as can be seen in the OCT also. So these are the 10 layers. So the innermost layer of the retina, to understand simply, you can say the skin of the retina. It's not the skin, but we can just think of it like that. So when you are coming down from the vitreous, the layer that you hit first, that is the skin of the retina, that is what we call internal limiting membrane, in short ILM, as can be seen by the arrows here. So we peel this ILM. Now why do we remove this? Because if you remove the ILM, even if there is some strand of vitreous which is sticking to the skin of the retina and which did not get removed in stage 3, once you remove this ILM, that strand of vitreous also gets removed. That is one advantage. Second, this ILM, if it is not completely removed of the eye, but rather a flap is made, and if it is used to close the macular hole, then that flap can act as a scaffold for the hole to close by tissue repair. So we will show you what that flap and all this means. So if you have a macular hole which is less than 400 micron but more than 250 micron, or you can say more than 300 micron, because as I said, if the hole is more than 300 micron, you need to do something about the ILM. But if the hole is not so big, so it's a medium sized hole, less than 400 micron, then what we do is known as conventional ILM peeling. In this, we basically remove the ILM all around the macular hole. So this is a video which shows how we do that. So here we are using diamond dusted scraper or Tenno scraper to initiate the ILM peel by creating a tear in the ILM, and then with the help of a internal limiting membrane forceps, we are just picking up the ILM and removing it. So we are just removing the skin of the retina. Remember, the layer just underneath the skin is what we call the nerve fiber layer, which is basically the one that carries the light to the brain. So if we pinch too deep, we will end up injuring the nerve fiber, retinal nerve fiber layers. That's why this layer, this whole step of peeling ILM has to be mastered. It looks very simple, but if not done properly, you can end up damaging the retinal nerve fiber layers, which will have a negative impact on the visual outcome. So if you have a hole which is less than 400 microns up to 400 microns, you do this conventional ILM peeling where we are removing the ILM all around the macular hole. But if you have a bigger hole, more than 400 micron, but not say beyond 750 micron, then a very popular and extremely innovative technique that has now come up over the last 10-12 years is what we call inverted ILM flap. And trust me, if we do conventional ILM peeling for such large size holes, the outcome is very unpredictable. But with inverted ILM flap, the success rate of closing a macular hole has really gone through the roof. So this is how we do an inverted ILM flap. Now you can see here I have initiated the peeling without using a diamond dusted scraper. So this is called direct pinch method. And you can see I'm not peeling all around, but rather I'm trying to create a flap and then folding it across the macular hole. And you can also see how big the hole is. You can also see this ILM is looking blue in color. That's because we have stained the ILM. It is not blue in color by nature. So we have stained it with what we call a brilliant blue dye, BBG dye, which is very widely available in India and also in Europe. But I think it might not be available in US. I'm not very updated on that. But we have been using BBG dye, brilliant blue dye, since 2007. And it's a very safe dye. So it not only stains the ILM, it doesn't injure the retina, unlike say the older dye called indocyanine green dye or ICG, which I have not used since 2007. But what if the hole is very large, more than 800 microns? Now in my experience in such a case, I have seen the results are better if instead of making a single ILM flap, we make multiple flaps and sort of stuff the macular hole with those flaps. If the hole is really large, more than 1000 micron, people have also suggested lens capsule autograft, ILM autograft, retinal autograft, even amniotic membrane transplant. But the reason why I've kept all this in white is because I have very limited personal experience with all this. So for practical purposes, I stop at this level. If the hole is beyond 1000 micron, sometimes we try this whole technique of multiple flaps, which I will show. But if it doesn't work, then I have to just refer the patient to a higher center. I have no access to amniotic membrane transplant. I did try retinal autograft once. It didn't really work out well in my hands. So this is how, in a very large hole, where we think that a single ILM flap may not be adequate, we can make multiple ILM patches, multiple ILM flaps, and then stuff those small flaps inside the macular hole. Now, unlike the previous video, you can probably appreciate one more thing in this. Again, I have started creating the flap by direct pinch. So for the last 4 or 5 years, I don't use diamond dusted scraper to initiate the peel, because now I become more confident. And you can see here, I have made multiple patches and I'm now just stuffing the hole with those multiple flaps, sorry, and I'm stuffing the hole with those flaps. You can also see the light is looking more yellowish than usual. This is because this surgery was done with Oatley's OS4 machine. It allows us to alter the light, and by altering the color of the light, if we make it more yellow than blue, it really assists by causing a high contrast situation where the blue internal limiting membrane, blue because it has been stained with BBG, stand out prominently. So now you have gone through 4 stages. You have entered the eye, done a central vitrectomy, and then checked whether any vitreous is remaining stuck to the retina. If it is there, you have induced a posterior vitreous separation. Then, depending on the size of the hole, you have also done either a ILM conventional peeling or a ILM flap, or maybe multiple ILM flaps. Next comes the 5th stage, where you have completed all this ILM peeling stuff, or maybe you have just completed vitrectomy and you know it's a small hole, you don't need to do anything more. Next, what you do is you replace the balanced salt solution inside the eye with a bubble of air. So you can see here, for example, I have peeled the ILM already. In this case, it's a conventional ILM peeling which we have done, and this is an inverted ILM flap which I have made. And now I am just replacing the balanced salt solution in the vitreous cavity with a large bubble of air. That's it. The surgery is now over, and we come to the last stage of our macular hole surgery, that is, we have to exit. And this is where micro-incisional vitreous surgery becomes so interesting. So previously, when we used to do what we call 20 gauge vitrectomy, which I have experience with, because when I was a fellow in Aravind Eye Hospital, Madurai, some 20 years ago, that was the way we used to do vitrectomy, 20 gauge vitrectomy. What used to happen is that we used to make large entries into the eye, and therefore those entry wounds had to be sutured. But now with this micro-incisional vitreous surgery, the exit happens in a flash, because all you need to do is just pull out these trocars, and the hole that has been made by this needle is so small, 0.5 mm, 0.7 mm, it's very small, so that it self-seals and you don't have to do anything about like suturing. This is a 27 gauge trocar, so here the hole is even more small or smaller or narrower. And same for the OS4, you can also see the metallic trocars of a Oatley OS4 system. You can just pull it out. And just, here what I'm doing is I'm injecting SF6 gas, which we usually, we can put if the hole is especially large, and that's it. Then you just close the eye. So you don't have to stitch anything. So it's a sutureless way of doing vitrectomy. So now that we have seen the steps of vitrectomy, the next question is obviously, the next question we decided to answer rather, which is something the patients often ask us, is how long does the surgery take and is it very painful? So here is a beautiful image from Zeiss Claras system, and you can see the gas bubble. This is the SF6 gas bubble. So this is 15 days post surgery from a macular hole. You can see there is no hole now. So I just kept this image because we are talking about macular hole surgery, and this is a post-op image from a patient who has been operated for macular hole. So the first question that we had was, how long does it take? And the answer would be on average 10 to 15 minutes, because you saw there are very few steps, very precise steps, and an uncomplicated macular hole surgery shouldn't take more than that. If a person also has cataract, then we can combine the macular hole surgery with a phacoemulsification and cataract, IOL implantation. That would be an additional 5-10 minutes. Next, is it painful? The answer is no. But when I say no, I always say that some people may be a bit more sensitive. But usually most eye surgeries, especially retina surgeries, unlike cataract surgeries, are done under what we call local anesthesia. That means we just paralyze the eye by giving some injections in and around the eye. And then if you have still some sensation, we can put some topical anesthesia. That means some drops which will further anesthetize your eye surface. Overall, the whole experience is not so difficult or troublesome. It doesn't take long. You will be alert and awake. You can communicate with your doctor because you are not getting operated under general anesthesia, at least not in our setup. And actually, to be very honest, I don't think anyone would be really operating a macular hole under general anesthesia unless the patient has some serious problems, like mental retardation, or patient is simply not cooperative, or there may be some other medical indications. So the third question, what precautions a patient should take after the surgery? So the instructions that we usually tell in our hospital, the Retina Institute of Bengal, to the patients are that you have to use your medications properly. We don't prescribe a lot of medication. We usually give a antibiotic steroid combination for 15 days and a cycloplegic. That means something that may dilate your pupil, but that will reduce the eye pain and inflammation for around 7 days. You have to maintain your eye hygiene. That is by cleaning the eyelids. You can definitely wash your face and do other activities, but usually we ask patients to be cautious about not allowing water to enter their eyes. Now this is more of an Indian thing, I think, because I have been thinking over it, because if you do a micro-incisional surgery, most of the wounds sort of seal within 48 to 72 hours. Now what will happen if by accident a drop of water enters my eyes? I don't think you will really get a bad infection. But in India, we are worried about post-op infections, and our patients are from all stratas of the society. Some of them, unless specifically we tell them not to put water in the eye, may even, not understand and actually put water in their eye. So we are little reluctant about being flexible about this instruction. So we tell our patients, clean your eyelids. Don't let drug precipitates or any sort of discharge get stuck around the eyelids. Clean them, keep your eye clean and nice, but don't let water enter your eyes for at least 10 to 15 days. Beyond 15 days, I don't have anything to tell the patient. They can go for normal bathing, putting water in their eyes and everything. That's what. The diet, again, this is something a lot of people ask in India. I think it is because of our Ayurvedic background. So in Ayurveda, diet plays a very important role in recovery. So I've seen all Indians are very insistent about क्या खा सकते हैं, क्या नहीं खा सकते हैं. But honestly, because all these are microsurgeries, we are not making large wounds. ऐसा कोई बड़ा wound नहीं है कि if you chew, the wound will open up. So ऐसा नहीं है कि आपको खिचड़ी खाना है, दालिया खाना है, पिघला के खाना है, उबाल के खाना है, ऐसा कुछ नहीं है. So I don't tell my patients to make any significant change in their diet. About bathing, as I said, you can definitely bathe normally under your neck. As for cleaning the hair, you can do that, but be careful not to let water enter your eyes at least for 10 to 15 days. But the one thing that is most important about macular hole surgery is something called positioning. So we ask our patients to maintain this head down posture. And this has evolved a lot over the years, especially since the inverted ILM flap technique came. So there are two things. One is, do I really need to maintain this kind of a strict prone positioning? Unless your hole is very chronic, very large, I don't think you really need to maintain such strict positioning. And my experience, even if you maintain this kind of prone positioning for a day or two, and then then maintain just lateral positioning. That means if you have been operated on the left eye, you sleep on the right side, that kind of a thing. That should be enough. So there was a time when people used to say you have to maintain this prone positioning for a month or so. Definitely not so. I tell my patients ki if you can, then when you are sitting, keep your head down for 5 days. And if you can maintain this prone positioning, be careful and try to maintain that for 2-3 days. But I have seen in general, it is okay if patients really cannot maintain such strict prone positioning beyond that 2 to 3 days time. And therefore, especially if the hole is not so big, it's a medium size hole, it's not a very large old hole, then I don't think maintaining this kind of a difficult position is really necessary. And that brings us to the last question. How long will it take to regain vision after the surgery? And this is the one question that cataract surgeons and retina surgeons have to keep on explaining, because in cataract surgery, you get back vision very fast. And the reason that happens is because we are replacing your sick lens with a normal lens. So basically, I have changed the part of the body that was not doing well. But in retina, we are not changing anything. So your retina has developed a hole. I'm repairing the hole. So I'm not changing your retina, I'm just closing the hole. And that is why the recovery is slow and steady. So the patient has to be patient. Yes, he has to wait for at least 3-4 months because vision will recover, but it may happen slowly. And there can be individual variations. So some people may say even at 15 days that they are already seeing well. Some may say that that I'm seeing now some difference only around say 2 to 3 months, because not everybody will get normal vision, that is 6/6 vision. Actually, very few people will get that kind of vision unless they have been operated early in their in the whole evolution of the macular hole. And then also I have seen that for the same vision, say a person has got back 80% vision, so that is around say 618, 612 vision. One person will be very happy with that 80%. Another person may not be happy. So this will vary. The only thing is, if the hole has been closed successfully, you will definitely feel better. The black spot in front of your eyes will go down. The distortion, that is the straight lines looking wavy, that will also go down. You will overall feel that I have improved, but it will take some time, so be patient. And as I said, the whole reason for that is retina surgery is not like cataract surgery. We are not replacing anything, we are just repairing things, and that is why the whole experience will be different. So I hope through this presentation today I could explain to you what are the steps of macular hole surgery. I could explain to you that we don't do all the steps in every macular hole. For example, step 3, where we induce PVD, may not be required in a stage 4 macular hole because already the vitreous is separate. And stage 3, where we are doing some manipulation on the internal limiting membrane, is optional. It's only for stage 2 or larger holes. And instead of saying stage, I should say it's only for holes which are around 300 micron or more in size. And what do we do? Do we peel the whole ILM, or we make a flap, or we make multiple flaps? That will depend on how big the hole is. So thank you friends for watching this, and please do let me know through the comment section whether I could actually answer all the questions. If you have any question which I've forgotten to answer, please don't hesitate to reach out to me. I'll definitely try to answer them through the comment section, or if I missed something significant and I need to make another video, I'll definitely do that. Now we will have one third video in this series, that will be the last in this macular hole series. In that third video, I will show a few examples of macular hole patients whom we have managed in Retina Institute of Bengal. There will be some interesting collection of cases, and I will show you how we applied all the principles that we have discussed in the last 2 videos to help close those macular holes. Thank you and see you soon.